Welcome back to Radong Smart Review, Thoracic Edition.
Glad to be back. This is going to be a fun one.
It really is. I mean, imagine giving a patient a higher dose of a life-saving treatment, only to realize that, the extra dose is exactly what killed them.
Oh, yeah. That's the ultimate nightmare scenario.
Right. Or imagine successfully clearing a tumor from the chest, only to trigger a fatal autoimmune reaction in the lungs because you didn't check a single molecular marker.
Which happens more than you'd think, unfortunately.
Exactly. So today, we're looking at these ultimate paradoxes and high-stakes pivots in thoracic oncology. We're pulling you, the listener, directly into the virtual clinic workroom with us.
Yeah, we want to actively explore the board-relevant management logic here.
Because the goal isn't just to, recite a list of clinical trials. We want to track how every single clinical fact, from a staging scan finding to a subtle shift in performance status to a very specific DNA mutation, has a direct consequence on your treatment plan.
Right, because knowledge in our field is really only as powerful as its precise application. To get there, you have to understand the biological and physical mechanisms driving these protocols.
Absolutely. So here's the roadmap for today's session. We're anchoring our discussion around 3 highly realistic clinical scenarios.
First, we'll dissect the approach for a fit patient with unresectable stage 3 non-small cell lung cancer.
Then we'll evaluate that exact same anatomic disease, but in a frail patient with limited physiologic reserve.
And finally, we'll shift gears into the rapid branching decisions you have to make when the biology accelerates in small cell lung cancer.
It's going to be packed. So let's just jump right in. You are sitting in the multidisciplinary tumor board, and the first case goes up on the screen.
Okay, set the scene for me.
You are presented with a patient who has biopsy-proven non-small cell lung cancer. The PTCT shows thoracic disease without any distant metastasis. The brain MRI is pristine.
That's a huge relief right there.
It is. Mediastinal nodal involvement is confirmed pathologically via EBS. Crucially, this patient has excellent functional status, robust cardiopulmonary reserve, and 0 major comorbidities. I mean, they are fit.
The dream patient.
Right. Now, the temptation here, especially for trainees, is to immediately start throwing out gray and fraction numbers.
Oh, absolutely. You want to jump straight to 60 gray and 30 fractions.
But the formula for a bulletproof clinical assessment, especially in a high-stakes board environment, requires establishing the foundation first.
You have to state the diagnosis, define the governing stage framework, and explicitly state your treatment intent before a single drug or dose is named.
Yes, because that framing dictates the entire downstream algorithm. So for this patient, what is your opening statement?
It should be very straightforward. This is pathologically concerned, unresectable stage 3, non-small cell lung cancer under the AJCC version 9 framework, and my treatment intent is definitive cure.
Boom. And planting your flag on the word cure immediately is so important because a definitive radiation field in the thorax is, it's a massive physiologic insult.
It really is. You cannot embark on that trajectory if there is occult disease sitting in a sanctuary site like the brain.
Which is why that high-resolution MRI is totally non-negotiable.
Exactly. Small, undetected metastases fundamentally alter the biology of the disease from locoregional to systemic. That shifts your intent from definitive cure to palliative or systemic first control.
Right. And we also demand that tissue confirmation from the EBUS. We don't just want a mediastinal node that glows bright on a PET scan.
No, because it could just be reactive macrophages from a recent bout of pneumonia or something.
Exactly. We want the pathologist confirming that the glow is actually driven by malignant cells.
Right. So, assuming we have all that, we take this package to the thoracic surgeon.
And the surgeon evaluates the patient and says, well, the patient is healthy enough for an operation, but I can't take this tumor out.
This introduces a massive semantic trap that trips up a lot of clinicians.
Yeah, conflating medical operability with anatomic resectability.
It happens all the time.
I always think of it like this. It's like having a car with a perfectly healthy, high-performance engine. That is medical operability. The patient's cardiovascular physiology can easily survive the stress of anesthesia, a double-lumen endotracheal tube, the whole thoracotomy.
But then you put that car on the road, and the road ahead is completely blocked by a massive landslide.
Right. That landslide is anatomic unresectability. The physical distribution of the disease, maybe it's encasing the pulmonary artery or it's invading the mediastinum in a bulky multi-station manner, it makes complete R0 oncologic clearance physically impossible.
The healthy engine versus the blocked road. I love that analogy. It perfectly isolates the variables.
It helps keep it straight.
Yeah.
Because the danger really arises when those two distinct concepts get blurred into this vague label of inoperable or uh, poor surgical candidate.
Which you see in clinical notes all the time.
Yeah.
But documenting a patient as broadly inoperable totally obscures the multidisciplinary logic.
Yeah, because a fit patient can have unresectable cancer. The engine is fine, but the road is blocked.
Exactly. And conversely, you can evaluate a highly resectable peripheral T1 tumor, a completely clear road, but the patient has severe pulmonary hypertension and just had a myocardial infarction.
The engine is failing.
Right. That patient is medically inoperable, but anatomically resectable. And that distinction is paramount because potentially resectable stage 3 disease might enter a surgical trimodality pathway.
While confirmed, unresectable disease mandates a definitive non-surgical strategy.
You must document the surgical opinion explicitly. Detail exactly which anatomical structures make complete resection unrealistic, because that specific distribution is what drives your radiation target volume later.
So, since the road is blocked for the surgeon in this case, the burden of local control falls entirely on us.
It does.
The standard of care is definitive, concurrent, platinum-based chemoradiation. But let's play devil's advocate and challenge the conventional dosing.
Okay, let's do it.
We have a young, incredibly fit patient with an unresectable tumor, and their physiologic engine is flawless. We want a cure. Historical standard is 60 gray, but why wouldn't we routinely escalate that dose to 74 gray?
I mean, it makes intuitive sense, right?
Right. If we know local failure is a massive problem in stage 3, shouldn't we just blast it with a definitively ablative dose to obliterate that local disease?
That exact logic, the assumption that more dose equals better local control and therefore better survival, was the bedrock hypothesis behind the RTOG 0617 trial.
It seemed biologically obvious at the time.
It did, but RTOG 0617 completely dismantled that assumption. The high-dose 74 gray strategy didn't just fail to improve outcomes.
It actually resulted in worse survival.
Yes, a statistically significant worse overall survival compared to the standard 60 gray arm.
Which is just wild to think about. And the mechanism behind that failure is fascinating, because it's not like the radiation suddenly stopped killing cancer cells at 74 gray.
No, the cell kill was happening. The failure was driven by the collateral damage, eclipsing the oncologic benefit.
Right. When we push to 74 gray in the thorax, we are inflicting profound microvascular damage on the heart.
And we aren't just looking at immediate pericarditis. Ionizing radiation induces endothelial cell apoptosis in the myocardial microvasculature.
And then months later, this manifests as myocardial fibrosis, ischemia, fatal arrhythmias.
Exactly. RTOG 0617 revealed that cardiac exposure, specifically metrics like the heart V50, and even lower dose baths like the V5, are massive drivers of overall survival decrements.
The cardiac toxicity was basically the silent killer in that trial.
It was. Furthermore, pushing a conventional fractionation scheme to 74 gray inherently extends your overall treatment time.
Because it takes more days.
Right. And when you prolong the treatment beyond 6 or 7 weeks, you give the surviving clonidins time to initiate accelerated repopulation.
The tumor basically outpaces the daily dose.
Yes. Add to that the severe esophageal toxicity.
Oh man, which degrades their performance status, causes severe cachexia.
And often forces patients to completely abandon their concurrent life-saving systemic therapy. When that happens, the survival curve inverts.
So the ultimate lesson from ARROW 617 is that target coverage, limiting overall treatment time, and strictly enforcing cardiac and esophageal constraints matter far more than chasing a larger nominal prescription number.
Perfectly said. You maintain the definitive prescription within the conventional 60 to 70 gray range, individualizing it to the specific anatomy and the systemic backbone. You do not routinely escalate to 74 gray simply because the patient looks robust in clinic.
Okay, so we know the dose ceiling. Now we have to execute the physics of the plan. And treating the thorax is essentially targeting a moving object inside a bag of shifting air and blood.
It's one of the hardest things we do dosimetrically.
It really is.
Right.
So when we acquire the 4D-CT, we aren't just looking at a generic blur to draw a static margin around, right? We are looking at the mathematical nuances of the respiratory cycle.
We bin the images by respiratory phase or amplitude, generating a maximum intensity projection, or MIP.
But relying solely on the MIP can be a huge trap, right?
Oh, a massive dosimetric trap. If the tumor trajectory isn't stable, or if the patient has an erratic breathing pattern, the MIP might artificially smear the density.
Which leads to an overestimation of the required volume.
And that overestimation ties directly back to the toxicity we just discussed.
Right, because if you indiscriminately expand your volumes, you radiate more healthy lung, more heart, and more esophagus.
Exactly. So we utilize the 4D-CT to generate a precise internal target volume that encompasses the gross disease across all phases of the respiratory cycle.
And we strictly utilize involved field treatment. We target what the PT and EBUS prove is involved.
We do not perform routine elective nodal irradiation, meaning we don't treat uninvolved mediastinal stations just in case.
Because the toxicity cost far outweighs any theoretical microscopic control benefit.
Spot on.
Okay, so let's say the dosimetrist finishes the plan and sends the dose volume histogram, the DVH, for our review.
The moment of truth.
Right, and the spreadsheet looks flawless. Lung V20 is under 30%, heart mean dose is well below the threshold, spinal cord max is super safe.
It's so easy to just sign off based on those mathematical summaries.
But a plan can pass every institutional constraint on paper and still be a total clinical catastrophe.
Because the DVH is just a one-dimensional mathematical summary of a three-dimensional anatomic reality.
Yes, the esophagus is the perfect example of this vulnerability. Your summary metric might indicate the mean esophageal dose is low, or the V60 is, well within limits.
But when you actually scroll through the axial dose distribution, slice by slice, you might discover a hot bridge.
A hot bridge. Explain that for the listener.
So the optimizer might have created a concentrated beam path where the maximum dose is blasting directly through a specific contiguous or circumferential ring of the esophageal wall.
Right, so the DVH says the total volume is fine, but biologically?
Biologically, that continuous structural ring is going to necrose and form a severe stricture or perforation.
Which is devastating for the patient. Or, conversely, look at the target itself. The optimizer might achieve that beautiful lung V20 by carving the dose away from the mediastinum.
It's just gaming the system.
Exactly. The spreadsheet says 95% of your target volume is receiving the prescription dose. But if you review the isodose lines slice by slice, you might find that the 5% that is underdosed, the cold spot, is sitting squarely in the center of a gross, hypoxic, EBS-proven lymph node.
And a marginal miss on a gross node cannot be accepted merely to force an organ metric into compliance.
The clinical priority is absolute. Every known site of gross disease must receive the intended dose with appropriate robustness to set up and motion.
If you identify that hot bridge or a cold spot in a node, you have to actively intervene. You ask yourself, can you modify the arc geometry? Can you adjust the optimization weighting or create avoidance structures to force the dose away from that specific esophageal wall without compromising target coverage?
Right. The plan demands rigorous 3D evaluation, pre-treatment physics quality assurance, and verification that your daily cone beam CT can actually reproduce that intended geometry on the treatment table.
Especially factoring in the interplay effect if you're using VMAT delivery.
Okay, so we've built the mathematically perfect plan, and the patient begins their concurrent chemoradiation. But around week 4, the cumulative biology catches up.
As it always does.
The patient develops progressive odynophagia. They are experiencing severe pain with swallowing, their oral intake just plummets, and they are becoming clinically dehydrated.
The instinct for many clinicians when a patient is suffering like that is to give them a break from radiation, to let the mucosa heal.
I mean, it feels like the compassionate thing to do.
It does. But yielding to that instinct without exhausting all supportive measures is a profound error.
The cardinal rule is to avoid preventable breaks.
Yes, because of the accelerated repopulation we mentioned earlier, your immediate step is aggressive medical management of the syndrome.
So you provide prompt, escalating analgesia, potentially requiring systemic narcotics rather than just topical anesthetics.
Right, the magic mouthwash isn't going to cut it here.
Right.
You also assess for and treat superimposed oral candidiasis. You institute aggressive intravenous hydration, modify their diet, and coordinate heavily with medical oncology.
Because manageable esophagitis should never trigger a casual dose reduction or a prolonged, unforced radiation break.
Never.
But if they cross the line into clinical instability, let's say they simply cannot swallow their own secretions, they are aspirating, or they develop sepsis from a port infection, we have to stop.
Of course, you cannot use the fear of accelerated repopulation to justify treating through an unsafe, life-threatening clinical condition.
Right. So they take a medically necessary 5-day break. They get hospitalized, hydrated, stabilized, and they return to the clinic to resume.
Okay.
But they missed 5 fractions. A very common board trap is the temptation to simply increase the dose per fraction for the remaining days to make up for the missed time and finish on the original calendar date.
Oh, that is dosimetrically disastrous
Why is that so dangerous?
because it alters the entire radiobiological foundation of the plan. The normal tissue constraints, particularly for late-responding tissues like the spinal cord and the brachial plexus, were calculated based on the alpha-beta ratio of standard 2-gray fractionation.
Right.
If you arbitrarily increase the fraction size to 2.5 or 3 gray, you exponentially increase the biologically effective dose to those late-responding tissues.
You risk catastrophic, irreversible late toxicity like radiation myelitis.
Exactly. Any compensation strategy requires rigorous, physics-driven replanning, often utilizing a hyperfractionated BD approach if you are truly trying to compress time. But you never casually increase the daily fraction size on the existing plan.
And beyond the radiobiology, the physical geometry has likely changed anyway.
Almost certainly.
They've been hospitalized for 5 days. They may have lost significant weight and muscle mass, which alters their external contour. Or internally, a pleural effusion may have developed, or an area of atelectasis might have resolved now that the tumor is shrinking.
If you put them back on the table and shoot the original plan, you are basically flying blind.
The tumor might have shifted completely out of the high-dose region, or normal lung might have expanded directly into it.
You must repeat the simulation, acquire a new 4D CT, and adapt the plan to the current anatomy.
Okay, let's advance the timeline. The patient successfully completes the 60 gray and their concurrent chemotherapy. The post-treatment restaging scans confirm no evidence of progression, and there's no clinically significant radiation pneumonitis.
Beautiful. So the evidence-based consolidation pathway here, established by the Pacific trial, is 1 year of durvalumab, which is an immune checkpoint inhibitor targeting PD-L1.
And the mechanism here is crucial for you to understand. The chemoradiation essentially acts as an in situ vaccine. We've caused massive immunogenic cell death, releasing tumor neoantigens into the microenvironment.
And the durvalumab blocks the PD-L1 axis. This prevents the tumor from suppressing the immune system, allowing the activated CD8-positive T cells to just hunt down micrometastatic disease.
But this is not an automatic prescription on a calendar. You have to carefully distinguish between expected asymptomatic radiation fibrosis and active immune-related pneumonitis.
Right, because the mechanism of immune-related pneumonitis involves those exact same activated T cells attacking healthy pneumocytes.
If you layer PD-L1 blockade on top of a lung that is already acutely inflamed from radiation,
The overlapping toxicity can be lethal. The eligibility assessment has to be meticulous.
but this brings us to a major inflection point. We have our fit patient, completed chemoradiation, scans are clean, but the molecular testing results finally return, and they reveal an activating EGFR mutation, specifically an exon 19 deletion.
Oh, wow. Okay, this single molecular fact completely derails the durvalumab pathway based on the Pacific trial.
It is a massive paradigm shift based on the recent LAURA trial. So why do EGFR mutations change the consolidation strategy so drastically?
Biologically, EGFR mutated tumors typically have a cold tumor microenvironment.
Right. They often have a low tumor mutational burden and lack the robust neoantigen presentation required to trigger a strong T-cell response.
Exactly. And because of this, they are notoriously resistant to single-agent immunotherapy. Giving durvalumab here provides minimal oncologic benefit.
Instead, the ALLUR-A trial dictates we pivot to molecularly selected targeted therapy, specifically osimertinib, which is a third-generation EGFR tyrosine kinase inhibitor.
And you cannot casually combine the two. You do not give osimertinib and durvalumab simultaneously or even in rapid succession.
No, the toxicity profiles, specifically the risk of severe fulminant pneumonitis, synergize dangerously.
TKIs can impair the repair mechanisms of type 2 pneumocytes. If you introduce an immune checkpoint inhibitor while those pneumocytes are vulnerable, the resulting inflammatory cascade is catastrophic.
The curative intent chemoradiation backbone remains standard, but the molecular mutation fundamentally redirects the consolidation phase away from immunotherapy and toward targeted TKI suppression.
That's a huge clinical pearl right there.
Okay, so we've built this elegant, high-dose curative plan, but it relies entirely on the patient's physiology acting as a sturdy foundation. What happens when that foundation is crumbling before we even start?
That brings us to our second scenario, the frail patient.
Yes. So this is, again, biopsy-proven, unresectable, stage 3, non-small cell lung cancer. The thoracic disease is technically encompassable within a radiation field, but this patient has severe limited physiologic reserve.
Give me some metrics.
They have an FEV1 of 0.8 liters, chronic ischemic heart disease, and recent unexplained cachexia.
Ooh, That's tough.
The immediate reflex for many is to declare them frail, assume they can't handle treatment, and default to a palliative pathway.
But equating frailty automatically with palliative intent is a clinical failure.
Right.
Frailty is a multidimensional signal, not a binary treatment endpoint. Your first responsibility is to determine the etiology and reversibility of that functional decline.
Is the patient frail because a bulky central tumor is causing post-obstructive pneumonia, hypoxia, and massive caloric expenditure?
Exactly. Because if so, treating the malignancy might actually reverse the frailty.
Conversely, is the frailty driven by fixed, irreversible end-stage cardiopulmonary disease?
Right. A patient weakened by active tumor biology may dramatically improve with treatment. But a patient with fixed baseline comorbidities will almost certainly decompensate under the exact same regimen.
You have to systematically determine which treatment sequence the patient can physically survive, explicitly aiming to preserve curative intent whenever possible.
But before we can even finalize that deliverability plan, we encounter the extrathoracic trap on the staging scans.
Yes. The primary tumor and mediastinum are intensely avid on the PET scan, but there is a single, isolated, faintly avid, indeterminate focus in a distant rib.
Just one little spot.
Just one spot. And we really want to cure this patient. The thoracic disease is clearly the dominant threat. The temptation is to write off the rib lesion as degenerative joint disease or a prior trauma and just press forward with the curative thoracic plan.
Ignoring that finding is a critical error in judgment. An indeterminate distant focus on a PET scan is neither a definitively negative staging finding nor a proven metastasis.
It represents a management-altering uncertainty.
Yes, if that osseous lesion is malignant, the patient has metastatic stage 4 disease.
And subjecting a frail stage 4 patient to 6 weeks of brutal, definitive thoracic chemoradiation provides zero overall survival benefit.
It accelerates their physical decline, and it delays the initiation of systemic therapy, which is the actual treatment for metastatic disease.
So the protocol requires resolving the uncertainty. We review prior imaging to see if the bone lesion is chronic. We get a dedicated MRI of that bony segment to evaluate for aggressive features like cortical destruction or marrow replacement.
But most importantly, we mandate tissue confirmation. You have to biopsy the lesion.
What if a biopsy is anatomically prohibitive or just medically unsafe?
Then the case must be adjudicated in the multidisciplinary tumor board. The team has to explicitly document how they weighed the probability of malignancy against the risks of treating the wrong stage.
You do not initiate definitive stage 3 treatment until that distant uncertainty is either pathologically resolved or consciously accepted by the entire multidisciplinary team.
Assuming the biopsy confirms the lesion is benign, maybe it's just an old fracture callus, we are back to stage 3 M0 disease.
We retain our curative intent.
We do, but we must address the patient's fixed, severe cardiovascular comorbidities. The multidisciplinary consensus is that delivering concurrent chemoradiation layering, the acute systemic toxicity of platinum doublets over the acute inflammatory stress of thoracic radiation carries an unacceptably high risk of fatal decompensation.
Or forcing treatment abandonment.
Right, so the evidence-based alternative here is sequential therapy. You deliver the full course of induction chemotherapy, allow for physiologic recovery, and follow it with definitive radiation.
Or if their renal or cardiac function completely precludes chemotherapy, we deliver definitive radiation alone.
But we have to be clear-eyed about the radiobiology we are sacrificing by separating them.
Right, because concurrent therapy is the gold standard, because platinum agents act as potent radiosensitizers. They inhibit DNA repair mechanisms, while the radiation is actively inducing double-strand breaks.
It creates a synergistic enhancement of local control.
So, by moving to a sequential pathway, we lose that spatial cooperation and radiosensitization. We are intentionally trading away a degree of oncologic intensity.
Yes, but we make that trade because an undeliverable perfect regimen is completely useless.
Exactly. Sequential treatment sacrifices that synergistic efficacy, but it converts a regimen the patient would definitively fail into a curative intent course they can actually survive and complete.
Frailty mandates a deliverability modification, not an automatic downgrade to palliative doses.
And this shifts the weight of our dosimetric trade-offs during planning. The technical rules remain identical. We still utilize 4D-CT, we still demand strict coverage of gross disease, but the clinical consequences of our organ constraints are hugely magnified.
In a fit patient, exposing a small volume of healthy lung to a moderate radiation dose might be easily tolerated.
But in this frail patient with marginal baseline pulmonary reserve,
that identical dosimetric exposure could precipitate permanent oxygen dependency.
Right. If they have severe baseline coronary artery disease, they possess zero physiologic reserve to absorb collateral radiation to the myocardium.
The dosimetrist must exhaustively optimize beam arrangements to protect those specific vulnerabilities.
And for a vulnerable patient, logistical support is not an administrative detail. It is a critical medical intervention.
You must architect the supportive care plan proactively. Who is managing their daily transportation? Which specific degree of weight loss or oxygen desaturation triggers a same-day medical evaluation?
If they develop a mid-course respiratory infection and require hospitalization, what is the defined pathway for reassessment and plan adaptation before restarting?
It has to all be mapped out. And oncologic surveillance post-treatment also shifts entirely.
We still acquire serial chest CTs to monitor the tumor, but our physiologic surveillance has to be hypervigilant.
A minor decline in mobility or a slight increase in dyspnea might be an expected hurdle for a fit patient, but can signal the beginning of a terminal downward spiral in a frail patient.
Crucially, if we suspect a locoregional recurrence 6 months later, our salvage eligibility is dictated by their current physiologic reserve.
Not the reserve they had before treatment began.
So true. Now let's reverse the biopsy outcome for a moment to illustrate the final twist for this patient. Suppose we biopsied that indeterminate rib lesion and it returns positive for metastatic non-small cell lung cancer.
Well, we are instantly dealing with stage 4 disease.
That single pathologic data point dismantles the entire locoregional algorithm.
The intent is immediately reclassified from curative to palliative or disease-modifying. Systemic therapy-targeted agents, immunotherapy, or chemotherapy assumes immediate dominance.
Even though the thoracic tumor is technically encompassable and hasn't changed size, we do not deploy definitive thoracic radiation.
Delivering 60 grays to the chest of a frail, stage 4 patient inflicts profound local toxicity without altering the trajectory of their systemic disease.
Radiation in that scenario is reserved strictly for urgent symptomatic palliation, like a short hyperfractionated course if the primary mass is causing critical airway obstruction, massive hemoptysis, or superior vena cava syndrome.
Right. We spent this time dissecting non-small cell lung cancer, where we often have the luxury of time to debate molecular pathways and sequential scheduling.
But what happens when the biology robs you of that time?
Exactly. Let's pivot to the rapid doubling time nightmare of small cell lung cancer.
Our third case is a patient with biopsy-proven small cell lung cancer. The brain MRI is negative. Comprehensive staging confirms no extrathoracic disease. The thoracic burden is encompassable within a tolerable radiation field.
The staging framework here is dual-layered, and we must utilize both.
Right. We document the AJCC version 9 TNM staging for precise anatomic mapping, exactly which nodal stations are involved, and the exact dimensions of the primary.
But we also mandate the Veterans Administration lung study group designation of limited versus extensive stage.
Why both?
Because they serve completely different operational functions. The TNM classification provides the geographic precision required to construct a safe, conformal radiation target. But the limited versus extensive designation dictates the systemic velocity and the overall therapeutic architecture.
So limited stage disease essentially signifies that the macroscopic tumor burden is confined to one hemithorax and can be safely enveloped within a single definitive radiation port.
Correct. For this fit patient, the intent is curative, utilizing platinum etoposide chemotherapy combined with early concurrent thoracic radiation.
The operative word there being early. Small cell lung cancer is a high-grade neuroendocrine tumor with an explosive proliferative rate and an incredibly rapid doubling time. It is a biological ticking clock.
The biological imperative is to initiate thoracic radiation concurrently with the first or second cycle of chemotherapy.
The overarching objective is to minimize the total therapeutic interval, the time from the initiation of any therapy to the completion of thoracic radiation.
Because if you delay radiation until all 4 to 6 cycles of systemic chemotherapy are completed, you concede a massive biological advantage.
The clonogens that survive the initial cytotoxic insult will just initiate accelerated repopulation between cycles.
You must integrate radiation oncology at the exact moment of diagnosis so that staging, simulation, and planning occur in parallel with the first chemo infusion.
Speed is paramount, but it must be coordinated, rigorous speed, not rushed or unsafe planning.
And this required speed creates one of the most classic targeting dilemmas in our field.
Oh yeah. Let's say systemic therapy starts immediately, By the time the patient is on our CT simulator 2 weeks later, the tumor has exquisitely responded to the platinum etoposide.
The massive primary lung mass has shrunk concentrically, and the bulky mediastinal lymph nodes have totally collapsed back to normal dimensions.
So what do? Do we target the massive original volume, radiating huge swabs of healthy lung, or do we target only the tiny residual disease, risking a geographic miss of microscopic clonogens?
This is exactly where we deploy the pre-nodes, post-primary rationale, or PMPP.
I love this mnemonic. PNPP, walk us through it.
The PMPP paradigm balances oncologic control against pulmonary toxicity. For the primary tumor in the lung parenchyma, we generally target the post-chemotherapy volume.
Because the primary tumor typically shrinks concentrically inward. Targeting the new, smaller volume safely spares a significant volume of normal lung tissue without compromising local control of the primary site.
Exactly, but the lymphatics are an entirely different biological environment. We must cover the initially involved pre-chemotherapy nodal geography.
Even if an EBUS-proven lymph node has structurally collapsed back to a normal size on the simulation CT?
Yes, because the microscopic disease within that specific nodal station and the permeation through the immediate surrounding lymphatic channels remain completely intact.
If you only target the post-chemotherapy nodal volume, you basically invite unacceptably high rates of regional nodal failure.
We encompass the originally involved nodes, but we still strictly avoid routine elective nodal irradiation of uninvolved stations.
Right. So once the target is defined, we face the most heavily debated decision in limited-stage small cell, the fractionation schedule.
Oh boy, here we go.
The foundational reference standard, established by Intergroup Trial 0096, is twice daily, or BID, treatment, delivering 45 gray and 30 fractions over 3 weeks, with a strict minimum of 6 hours between the morning and afternoon sessions.
I know you're going to challenge this.
I'm absolutely going to challenge the BID standard. Subjecting a patient who is already systemically battered by concurrent chemotherapy to 2 radiation treatments a day, 6 hours apart, for 3 weeks. It is a massive logistical and physical burden.
It is exhausting for them.
And furthermore, the 0096 trial compared 45 gray by D against 45 gray delivered once daily over 5 weeks. Biologically, 45 gray once daily is a profoundly low dose by modern standards.
It wasn't exactly a fair comparison.
Not at all. So why not deliver a much higher dose once a day, save the patient the logistical nightmare, and achieve the exact same cell kill?
And that exact challenge drove the modern definitive trials. The CONVERT trial in Europe and salvage 3610 in the United States. They sought to determine if a high-dose, once-daily regimen, typically 66 to 70 gray, could prove superior to the 45 gray bead standard.
And they failed to prove superiority.
Correct. The BD regimen maintained its status as a co-reference standard, demonstrating excellent survival outcomes. However, the trials did establish that high-dose, once-daily treatment is a highly effective, safe, and statistically comparable alternative when utilizing modern conformal planning.
So the decision between the two really hinges entirely on patient logistics and pulmonary anatomy.
Yes. If the patient lives 2 hours from the cancer center and lacks the resources to remain on-site for 6 hours every day, BD is a catastrophic choice because they will likely just abandon treatment.
And the biologically optimal regimen that a patient cannot finish is clinically worthless.
Exactly. But if we do switch from BID to once-daily treatment, we cannot simply use the exact same organ constraint spreadsheet.
That is a dangerous, schedule-specific error.
The radiobiology of fraction sizes dictates fundamentally different effects on normal tissue repair. The safety of the BD regimen relies heavily on the sublethal damage repair of normal tissues, like the spinal cord and lung parenchyma, occurring during that strict 6-hour interval.
Because the alpha-beta ratio of small cell lung cancer is high, meaning it is exquisitely sensitive to fraction size.
While the late-responding normal tissues have a lower alpha-beta ratio, making them heavily dependent on repair time.
A 1.5 gray fraction delivered BD imparts a completely different biological effective dose to the esophagus than a 2 gray fraction delivered once daily to a much higher total dose.
You must interpret your dosimetric constraints through the specific biological lens of your chosen fractionation scheme.
Absolutely. Let's look at systemic toxicity during this concurrent phase. Say the patient becomes severely neutropenic. The medical oncologist wants to administer a myeloid growth factor to stimulate white blood cell production and keep the chemotherapy on schedule.
Okay.
Historically, administering growth factors during concurrent thoracic radiation was considered an absolute contraindication. This was based on older data where the use of routine GM-CSF granulocyte macrophage colony stimulating factor was linked to fatal overlapping toxicities, specifically severe thrombocytopenia and massive exacerbations of radiation pneumonitis.
Right.
Is that still a universal ban?
It is no longer a blanket prohibition because the evidence era and the specific pharmacological agents have evolved. A highly important secondary analysis from the modern CONVERT trial evaluated the use of prophylactic GCSF granulocyte colony stimulating factor, which is a different agent.
And what did it show?
It demonstrated that it safely reduced the incidence of febrile neutropenia without significantly increasing the rates of severe radiation pneumonitis or mortality, although it did slightly increase thrombocytopenia.
So you must distinguish between the specific growth factors and individualize the decision in a multidisciplinary setting based on the patient's immediate risk of fatal neutropenic sepsis versus the potential radiation interaction risks.
Precisely. We're also seeing rapid systemic updates in the consolidation phase. We discussed the PACIFIC trial for non-small cell using durvalumab.
Right.
Well, the Adriatic trial is now mirroring that paradigm for limited-stage small cell, introducing durvalumab consolidation following concurrent chemoradiation.
The survival signals are highly promising, and guidelines are rapidly integrating this pathway.
But it requires the exact same meticulous assessment for overlapping immune and radiation pneumonitis that we discussed earlier, especially given the larger target volumes often required in small cell.
Okay, so the most intense conversation you will have with a small cell patient occurs after a thoracic treatment is complete. The chest radiation is finished, the chemotherapy is done. The post-treatment scans show an exceptional response. Crucially, the high-resolution brain MRI is completely negative for metastatic disease.
And the patient asks, do I really need radiation to my entire brain?
Right. Historically, prophylactic cranial irradiation, or PCI, was considered universally mandatory for limited-stage responders based on meta-analyses demonstrating a clear overall survival benefit by eradicating micrometastatic disease.
But a critical caveat is the era in which those foundational trials were conducted.
Yeah.
They predated the widespread use of high-resolution modern MRI.
Patients were staged with low-quality CT scans.
Yes. A significant percentage of patients presumed to have negative brains actually harbored undetected macroscopic metastases.
So the PCI in those historical trials was likely acting as definitive treatment for existing disease, which is what drove the profound survival benefit.
Today, if a high-quality thin-slice MRI confirms a truly negative brain, the probability of pre-existing microdisease is substantially lower.
And we must weigh that against the known toxicity of whole brain radiation. Even with modern hippocampal avoidance techniques, PCI carries a real and significant risk of progressive neurocognitive decline, cortical atrophy, and quality of life degradation, particularly in older patients or those with baseline cerebrovascular disease.
The modern alternative to PCI is rigorous MRI surveillance.
But this requires an explicit understanding. MRI surveillance is not passive observation.
No, it is an active clinical commitment to early detection and immediate salvage therapy, typically utilizing highly targeted stereotactic radiosurgery to ablate oligometastases if and when they appear, sparing the whole brain.
It demands absolute patient compliance. The patient must reliably return for frequent, scheduled MRIs, often every 3 months.
If the patient lives in a rural area, lacks reliable transportation, or exhibits poor compliance, surveillance is oncologically dangerous. For those patients, PCI remains the safer strategy to prevent a catastrophic symptomatic brain failure.
The decision must be highly individualized based on the patient's neurocognitive baseline, logistical resources, and personal values.
To close out the small cell discussion, let's explore the extensive stage twist.
Let's do it.
Suppose during initial staging, an equivocal liver lesion is biopsied and returns positive. The patient has extensive stage small cell lung cancer. The paradigm immediately shifts to systemic dominance.
They complete systemic chemoimmunotherapy and achieve a fantastic distant response. The liver metastases vanish. However, they retain a bulky, glowing mass of residual disease in the thorax. Do we consolidate the chest with radiation?
This is the specific role of consolidative thoracic radiation in extensive stage disease, heavily informed by the CREST trial.
The trial evaluated delivering thoracic radiation to extensive stage patients who had responded systemically.
And the data showed a significant reduction in intrathoracic progression and a signal for improved 2-year survival, particularly in the subset of patients who specifically retained residual thoracic disease while their distant metastatic sites were well controlled.
It is a highly selective tool used to prevent devastating local complications like airway compromise. but its interaction with modern maintenance immunotherapy requires ongoing multidisciplinary review.
And regarding the brain in extensive stage disease, the role of MRI surveillance over PCI is exceptionally strong.
Right, a landmark Japanese randomized trial specifically evaluated extensive stage patients with negative baseline brain MRIs, randomizing them to PCI versus strict MRI surveillance with salvage stereotactic radiosurgery.
And while the PCI arm experienced fewer brain metastases, there was absolutely zero overall survival benefit to administering PCI over strict MRI surveillance.
It validated surveillance as a highly evidence-based strategy to spare these patients the cognitive toxicity of whole brain radiation, provided they have access to high-quality imaging.
Okay, to synthesize these complex decision trees, let's execute a rapid-fire board review. I will present the clinical variables, and you define the operative takeaway.
I'm ready. Hit me.
Scenario 1. A fit patient with unresectable stage 3 non-small cell lung cancer completes concurrent chemoradiation with no progression. Molecular profiling reveals an EGFR exon 19 deletion. What is the immediate clinical pivot?
The takeaway is osimertinib, guided by the RRA trial. You do not reflexively administer durvalumab based on the Pacific trial simply because the stage matches. The EGFR mutation defines a cold tumor microenvironment resistant to immunotherapy, and combining TKIs with IO carries an unacceptable risk of synergistic pneumonitis. The molecular data redirects the entire consolidation strategy.
Perfect. Scenario 2. A patient presents with confirmed unresectable stage 3 non-small cell disease. The intent is curative. However, they possess severe fixed cardiovascular comorbidities, rendering concurrent chemoradiation physiologically unsafe. What is the appropriate strategic modification?
The takeaway is that sequential therapy delivering chemotherapy followed by radiation, or definitive radiation alone, preserves the curative intent. You are intentionally trading away the synergistic radiosensitization of concurrent therapy to convert a lethal regimen into an architecturally deliverable one. You do not automatically downgrade to palliative intent simply because the standard concurrent regimen is unsafe.
Spot on. Final scenario. A patient with limited stage small cell lung cancer is midway through concurrent chemoradiation. They develop severe neutropenic sepsis and profound dehydration from esophagitis. What is the mandatory next step?
The takeaway is that acute patient safety supersedes the biological fear of accelerated repopulation. You immediately interrupt radiation, stabilize the sepsis, and provide aggressive supportive care. Crucially, upon recovery, you do not simply resume the original plan or arbitrarily increase the daily fraction size to compensate for lost time, as that risks catastrophic late toxicity to the spinal cord. You reassess the patient, acquire a new simulation scan to account for geometric changes, and adapt the physics plan deliberately.
Excellent. If we look at the entire spectrum we've covered today, the fit patient requiring aggressive local control, the frail patient demanding logistical preservation, and the rapid biological shifts in small cell, the fundamental truth is that a mature clinical recommendation is never static.
It's always evolving.
It adapts continuously based on a cascade of variables: the precise anatomic map, the molecular profile, the patient's dynamic physiologic frailty, and the evolving dosimetric physics. It requires understanding the underlying cellular biology and adjusting your logic to protect the specific patient in front of you.
We are constantly evaluating the capabilities of the engine against the realities of the road ahead. We are moving into an era where technologies like circulating tumor DNA might soon tell us exactly who is harboring minimal residual disease after chemoradiation and who is already cured, potentially making our current reliance on anatomic PET scans look archaic. But until then, the clinical logic we mapped out today remains our strongest tool. Get show notes and complete practice oral boards at radontsmartlearn.com and subscribe for our next episode. Thanks for tuning in.